Now, fungal infections then, when we talk about in critical care, are the ones we are not concerned about the mucocutaneous, but the deep organ infections, particularly the opportunistic infections coming in patients who are immunoparalyzed or those who are on immunosuppressive agents, those with certain comorbidities prone to certain infections. And therefore, I would cover those in 4 different scenarios. But before that, just a brief review of how the antifungal agents have antifungal agents work. These agents kill fungi at different levels, and this is not to confuse you, but this is fungus cell wall, and there's different parts of the cell wall that are being targeted by these drugs. The pollines that we use most often, that is amphotericin, works on this ergosterol mechanism and the cell wall damage. Echinocandins also work in the same pathway but differently. Azoles and other ones are actually not much used, the fluorocytosine in pediatric ICU at least. So these are the groups of antibiotics: pollines, azoles, fluorocytosine, and echinocandins, among which the commercially available is capsofungin, and among the pollines it's the amphotericin that we use. Among the azoles that we have, voriconazole and posaconazole. The voriconazole, itraconazole, and fluconazole. Fluconazole being the oldest which is being used in ICU. I will try to summarize how we can use in different scenarios. And 4 different scenarios are previously well child admitted in ICU with prolonged fever, even prolonged fever after multiple antibiotics in ICU or even before that. A neonate in NICU with a prolonged stay with presumptive or proven candida. A child with diabetes or DKA with possible fungal infection mucor, and a child with febrile neutropenia. So let's look at the first one. Now, in pediatric ICU, the most often, one of the causes of prolonged fever, particularly after prolonged antibiotic therapy, is candida infection. And this is our data which we had published twice. This is from 2007, from 64 patients earlier, and this is from almost similar number. The most common in our setup is Candida tropicalis, which is, unlike albicans, not so sensitive to fluconazole. But there are also many other atypical ones, pelliculosa, cruz, and Guillermandi. These are the 3 very common ones besides the albicans, which is a very small proportion of Candida in our setup. And in these patients, when there is an invasive infection, because these are all blood culture positive we are talking about, use of amphotericin had been quite helpful. But if you look at the sensitivity in our setup, my colleague in microbiology works a lot on this area, and these are the data which were published just a year and a half ago. If you look at the sensitivities to fluconazole, voriconazole, itraconazole, the newer ones, to azoles, there's not much of sensitivity to azoles for any of these candida. And therefore, azoles are not the drug that you would use for yeast, that is mostly candida. But in spite of that, for the infections which were not deep invasive or like urinary tract infections and those, or those not associated with signs of sepsis, use of azoles had a clinically quite satisfactory outcome with use of fluconazole. But amphotericin, of course, was used only when fluconazole haven't worked, but it works almost equally well. In our ICU, when we looked at the data, which I do not have slide here, amphotericin was effective in almost all those where we had used it. The mortality in our setup with candida in ICU is much lower. So in non-neutropenic patients with candidiasis, if your place doesn't have a known fluconazole resistant, fluconazole intravenous or parenteral could be quite okay. But if that is not working and you have the sensitivities available, more appropriate would be amphotericin. I think the experience from other places is an older one. The fluconazole is also a useful drug for cryptococcal meningitis and other coccidic dietal meningitis. In cryptococcal meningitis, we again use it along with amphotericin. And I'll not go into detail of the CNS fungal infections because they are much less common. And this drug is used in doses of 6 milligram per kg. Loading dose followed by 3 mg per kg. The most important aspect of this drug is very safe drug and could be used for a longer period. In general, we would use them in candidiasis, whether amphotericin or this, for about 6 weeks or when the culture comes negative. I'll discuss amphotericin a little later, the other forms. Now, caspofungin is a new class of the antifungal agent, and it exerts activity by non-competitive inhibition of, as I showed on the wall, the D-glucan, which is an essential cell wall complex polysaccharide. And this, therefore, has dual benefit. One, there are fewer side effects as the cell wall are not being affected in the human cell, and there is a possibility of combination with other agents which can act synergistically. All drugs in this group have poor oral availability and therefore they have to be given IV, and that's true for caspofungin as well, and has a long half-life and therefore it can be given once a day. The metabolism is not dependent on renal or hepatic function, and therefore again you don't have to modify the doses. The loading dose is 70 milligram per meter square and is followed by 50 milligram per meter square daily. It's available commercially as 50 milligram vial, and the cost is prohibitive, 10,000 rupees per vial. Therefore, where we use it is only when the amphotericin has failed in East. The clinical trial on this in pediatric are very limited data, but all that so far could be made out from available literature is that it's as good as amphotericin, but not superior, at least in ours, from the published data. It has fungicidal activity against all kinds of candida, and that's the major advantage. It also has fungicidal activity against Aspergillus. And it also works against pneumocystis. But it lacks activity against Cryptococcus, and therefore one wouldn't use that because Cryptococcus doesn't have cell wall D-glucan. Now, as I mentioned, about only one multicentric study has shown that overall it is favorable and safe and can be used. In adults, though, this would be a drug which may be preferred over amphotericin in treatment of invasive candidiasis. The biggest advantage, of course, which happens with almost all new drugs, are that we initially say that they are safe, and afterwards we find all the toxicities with those. So, but the cost is prohibitive, and I don't think I would recommend that as the first-line drug anytime in our setup. The second scenario is a neonate in NICU with prolonged stay and presumptive or proven candida. Now, candida colonization in newborn is very common, in fact, but not all of them have disease. So one has to differentiate between this colonization and disease. But in infants below 1500 grams, this is very often maybe leading to invasive candidiasis. It's a similar mechanism that works also in the older patients. Once there is a colonization, there is that precedes the deep invasive infection. And in these patients, there are several risk factors that had been identified. I don't think I'll go into that. But here again, because of their age, because of their vulnerability, amphotericin is the drug of choice if there is a systemic candidiasis. But fluconazole had been used, and there was a paper published even from our neonatal unit a few years ago, where they found fluconazole was quite effective. But since then, there had been a change in the pattern, and there had been more resistance. Fluconazole has suffered from this. Wherever it had been used for prophylactic purposes, has led to more resistance, and this has led to, again, falling back upon amphotericin as the drug of choice for systemic candida. In a child with febrile neutropenia, fungal infections are important cause of morbidity and mortality. And most common again in these patients are these molds, are yeast, but sometimes molds also. And part of the problem that is increase in the mold infection is because of widespread azole prophylaxis, which is what I was saying, that the fluconazole particularly had been used for prophylaxis. Now they have a lot of risk factors, that immune status, steroid uses, modifies again, and that puts them at risk for, again modifies their various immunological function and puts them at risk of aspergillus infection. And because of these indwelling catheters, broad spectrum uses, and other, they are also prone to invasive candidiasis. Therefore, in these patients, when we talk about empirically covering, we are concerned about covering both of these. I think I'll skip this slide. Now, which antifungal, therefore, one should use? They are susceptible to, as I showed, to all kind of fungi, but particularly the aspergillus and yeast. And therefore, it is important that one tries to identify which fungus is it through various tools, including PCR. But in such patients, at least a chest CT, HRCT can give a clear view of aspergillus. Candida may be difficult to identify. However, if you are not sure, in these patients, empirically, a broad-spectrum antifungal drug is recommended. And so far, we have always used amphotericin in these patients. But more recently, voriconazole is the drug that is also being used. Sometimes, in fact, both. But voriconazole has the advantage of being used orally, whereas you have to give amphotericin IV. So these are the various drugs that one can use. Amphotericin, liposomal and lipid complex are less toxicity, voriconazole and posaconazole, and among echinocandins, caspofungins. If you look at the data again, published one, in these febrile neutropenic patients, aspergillus and candida are the two most common, whether you take autopsy evidence from this time period or the previous time period. Again, these are the data from our institution. And in both these, therefore, it would be difficult on empiric basis to exclude one for other. And our hematology group these days prefer voriconazole over the others. And you can see that it almost covers all the species that can cause infection except zygomycosis. But then you don't cover it with any other azole as well. But most of these azoles have a broad spectrum cover against Candida, Cryptococcus, Aspergillus, and also other hypomycetes, which is not true for caspofungin. You don't cover Cryptococcus there, and you don't cover the others. It also needs an IV, whereas with voriconazole, you could go with IV initially and follow it up with oral doses. So now in these patients also prophylactic use, and there had been a lot of studies on prophylactic use with all kind of azoles Fluconazole, itraconazole, voriconazole all had been tried, and to some extent they had been all useful. But with voriconazole, there had been increased incidence of mucormycosis because it's not working against zygomycetes, and therefore there is selection and increased incidence of mucor. Posaconazole also had been successfully used. So if you want to use for prophylaxis, any of the azoles, including the newer ones, can be used. Voriconazole in particular has found much more use, as I had been mentioning earlier, and it is developed from fluconazole. It achieves fungicidal activity against Aspergillus and other molds, but not against zygomycetes, as I said earlier. And it can be used as oral and IV both. Orally, when you are giving it, should be given on an empty stomach, and the drug is rapidly and almost completely absorbed from the oral route. Oral dose does not have to be adjusted for, as I mentioned again earlier, for liver or renal disease. It is not approved by FDA, but there are many other drugs, so if it's life-saving, it may be used. The pediatric dose is about 11 milligram per kg administered every 12 hours, which is equivalent to about 4 milligram per kg given to the adult dose of every 12 hours. The problems with this drug are prolongation of QTc, so there is a risk of cardiac arrhythmia, but then you heard in the previous talk also, most of the antimalarials have that same thing. It's a life-saving drug, and when it's needed, one would, of course, monitor it, but the drug is not contraindicated. Recent Indian reports have shown that it can be used in neonates with cardiac disease without much untoward effects. Patients should also be warned about the visual effects, and the transient visual change can occur in 30% of these patients, beginning about half an hour after the drug had been given. But then it's not lasting and there is no sequelae. Blurred vision, altered color perception, photophobia may also occur, and that may have a concern, and therefore one need to monitor for it. It has not yet been formally tested in newborn for this purpose. I have already said about voricnozole's use in invasive Aspergillus in particular, and for febrile neutropenia. It's superior to amphotericin for Aspergillus, invasive aspergillosis. Okay, now this is. The drug is available as 200 milligram tablets, which cost us 320 rupees, and IV preparations not easily available and is more expensive. Other drugs, amphotericin for febrile neutropenic patients, conventional, cheaper, but with all kind of difficulties and the side effects. Liposomal and lipid complex, they are all meant to reduce the toxicity and increase the tolerance, and probably therefore you can give higher dose. They all work at ergosterol mechanism in the fungal cell membrane, as I had said earlier. It's insoluble in water and has to be given by IV. It's excreted unchanged in anephric patients and patients receiving hemodialysis. Little amphotericin B penetrates CSF, and therefore once you're treating CNS infections, you have to use higher doses. But there had been people who have used intrathecal and intrathecal doses, but it hasn't made any difference to the outcome. In CNS infections, however, amphotericin remains, if you have to treat candida, amphotericin B remains the drug of choice. The dose is very variable, although the conventional dose, but with the lipid formulations, you can use much higher dose than this 0.5 to 0.6 milligram. In rapidly progressive mucormycosis or in invasive aspergillosis, the dose has to be doubled until the progression is arrested. I think I'll Okay. The side effects of this, that azotemia occurs in a large number of patients receiving conventional amphotericin B, and the toxicity is dose dependent, therefore one uses a certain amount of the time period over which the dose is given. Renal tubular acidosis, renal wasting of potassium and magnesium can occur, and in fact it's one of the very frequent reason for changes in both these electrolytes. If you are using it in your ICU, you should be monitoring for magnesium and potassium. Liposomal is therapeutically no different. It's lipid package formulation of the drug. It prevents non-specific binding to the human cell and therefore reduces the toxicity. And it will be delivered directly to the site of fungus. But for that, you would probably pay 4 to 5 times more money, which most of our patients cannot afford, but I'm sure Dr. Taneja's patients do. 10 milligram costs 1800 for liposomal, 7,000 rupees, which is almost much more than the conventional one. The final one is a patient with DKA and coming with fungal infection. I'm sorry, I wanted to show you a picture of a patient whom we treated a few months ago, 2 months ago, who had come with reddish, violaceous hue on the right side of the face, with bleeding from the right side of the nose. And this child was known to be a diabetic, and our immediate concern was about mucormycosis. These are the patients, typically mucormycosis is seen in patients who are acidotic and who are hyperglycemic. So in patients with renal disease and in patients with DKA, this is one dreadful infection. But if it is diagnosed and treated in time, one can salvage these patients. In these patients, when you are treating mucor, polines and echinocandins and posaconazole, they are all effective. We generally use amphotericin as the first line, but in these patients. So what I would like to conclude by saying is that you have all these drugs, they have their advantages and disadvantages. Among the newer ones with echinocandins, voriconazole and posaconazole, you have better coverage of resistant organisms, but with voriconazole in particular, aspergillus in febrile neutropenic patients, much better fungal coverage can be obtained. Well, if you are aware about their side effects and toxicities, things can be taken care very well. Thank you very much.